Okay, it is my pleasure and my honor to introduce Dr. Diana Finkel, who has been privileged to provide care for diverse populations at risk, including immigration detainees, LGBTQ, marginally housed youth, and persons who use drugs for almost 2 decades. She is deeply committed to ensuring access to state-of-the-art, highest quality medical care for all individuals in Newark, New Jersey. Her passion to provide inclusive, complete care to the transgender community led to her develop a comprehensive urban community health center-based clinic that provides primary care, HIV care, PrEP, and gender affirmative hormonal care. She is fortunate to serve as a clinical director of the Transgender Health Program at NGCRI, a comprehensive community-based organization. And so she is going to be speaking to us about medical care of gender diverse individuals, hormones, and beyond. Thank you, Dr. Finkel.
All right, I'm going to minimize my own screen so I don't have to stare at myself. So hello, everybody, and welcome. So a disclosure, I'm not a surgeon. However, today we're going to talk about medical care of gender diverse individuals because it's very important for all providers, all clinicians, all physicians, surgeons, and everyone else to be able to be culturally responsive to the diverse community we serve. I am an associate professor in the Department of Medicine, Division of Infectious Disease at Rutgers, New Jersey Medical School in Newark as well. You already heard some of the other stuff from my community work. So the learning objectives for this talk would be to define key terminology related to gender identity, describe the demographics of gender dysphoria, as well as health-related disparity amongst transgender individuals, delineate some of the key steps in developing a supportive gender-affirming clinical environment, and providing culturally responsive care for your transgender clients, and outline general approaches to holistic care for individuals who are transgender or gender or have gender non-binary experience, including mental health, gender-affirming hormones, and preventative care and treatment. Because this is all really about medical care, holistic care, whole care of an individual, not just hormones, not just surgery, not just anything, more like actual medical care. So these are my references: the World Professional Association for Transgender Health, Standard of Care version 8, the Callan Lord Community Health Center, Protocols for Provision of Hormonal Therapy, the National LGBTQ Health Education Center, and the University of California, San Francisco Transgender Care Guidelines, the Endocrine Society Guidelines. And there in the corner, you can see a picture of the standards of care. They're available online at that website up there. So a little bit about statistics and demographics. So I know, I'm based in New Jersey, so I do have New Jersey statistics, but we will also go over the map on the bottom there of the LGBT proportion of the population. So intersex or individuals who suffer from disorders of sexual development currently include about between 1 in 200 to 1 in 100 individuals. Some of the disorders of sexual development may carry increased risk of morbidity and mortality. For example, congenital adrenal hyperplasia, while others might not. And some individuals who have DSD may have been exposed to iatrogenic harm with corrective, quote unquote, surgery in childhood and might have issues related with that. LGBTQ population, so the LGB portion of it is an estimated 8.2% of Americans who report same-sex behavior. Another 3%, additionally, about 11% report same-sex sexual attraction. About 4.5% of the US population identify as lesbian, gay, or bisexual. Statistics over there about the map of the LGBT proportion of the population. In New Jersey, that's about 33,000 folks, while in the US, it's, as you can see, it's according to the Williams Institute, it's 0.58% or 1,300,000 approximately. Of course, the youth survey, they have a much higher proportion of folks who identify as trans, so about 2%. The population of youth in school right now, the generation Alpha / generation slash Gen Z are actually one of the most sexually and gendered diverse populations. So a lot more of them identify as trans than the rest of the population. So the population there in the corner there will show you the percentages of folks that identify as LGBT. So as you could see, some of the greatest, highest concentrations are actually along the West Coast and also in Florida, which is currently a state that's facing anti-trans legislation. So wrong direction, everyone. Moving forward. So why is it important to understand gender, sex, and their intersexuality and sexuality in general for everybody? So basically, sex and gender identity and sexuality are all essential dimensions of identity and of the human experience. We demonstrate an expansive diversity, which we're still learning about as a species. These things have major impacts on health status, health risk behavior, healthcare access, and social determinants of health. Celebrating and fostering sex, gender, and sexual diversity in our educational as well as clinical spaces can improve healthcare for all patients, including cisgender and hetero-identifying patients. So a little bit about a label. What's the label deconstructed? Though grouped together, LGBTQIA+ populations are diverse, complex, and dynamic individuals. All people are unique by sex, gender, and sexuality. Gay men and lesbian women have very different health needs. Transgender and cisgender people face distinctly different healthcare and societal issues. Gender questioning or non-binary folks may have very different needs and experiences altogether than transgender individuals. Intersex/DSD individuals may or may not have special health risk or have faced iatrogenic harm. It depends on the individual. We have to make no assumptions. You expect to encounter a diverse population of identities revolved around sex, gender, and sexuality. Sexual orientation may not align with a person's sexual history, practice, or identity. Intersecting identities related to race, ethnicity, age, religion, socioeconomic status, and geographic location can influence health risk and healthcare needs. Why should we understand sex, gender, and sexuality? It enhances our communication and trust in the patient-physician relationship. Beyond sexual health, LGBTQ populations and identity can impact physical and mental health. It provides us more clarification of health issues and disparities and helps inform a differential diagnosis. It will help us understand family structure and support network. Who exactly is going to be taking care of your patient after their cardiothoracic surgery? Offers opportunities to enhance patient education, prevention, and alternative health services. It is an opportunity to connect with your patient and to provide the best kind of care possible. There are different health disparities in the LGBT population along the life cycle. For example, individuals with DSD may have experienced iatrogenic harm through surgery early on in their childhood. They may have chronic complications from genital reconstructive surgery. They may experience trauma and disability related to that. Lesbian and bisexual women have an increased risk of metabolic dysfunction in some studies, eating disorders, asthma, cervical and breast cancer, and CVD. And they're also experience disability earlier on than hetero women. Gay and bisexual men may have increased sexual risk behaviors related to HIV, for example. Eating disorders are also possible in this population. HIV and STIs may be a concern. Anal cancer, an up-and-coming disease state for our aging population. It might be higher in this group, as well as CVD and general disability. Transgender individuals face underinsurance. They experience delay in medical care. They have experienced denial of medical care. HIV and STIs might be also a risk for those who are engaged in behaviors that might be associated with increased risk. Cardiovascular disease may be disproportionately higher in this population. There may be effects from hormones as well on cardiac health. HPV-related cancers are also a problem here, and many experience earlier mortality than their cisgender cohorts. The community in general, LGBTQ population has a higher use of tobacco at times. Substance abuse is at increased risk. There may be less physical activity. Depression, PTSD, suicidal ideation are all higher in this population than in hetero-identifying adults, and many have experienced trauma and violence. This is a very busy slide, apologize. But the main take point of this is that health risk can be driven by various levels. There's a biological level, which may be impacted by hormones, silicone inflammation, biological inflammatory effects of chronic stress, and might be associated with specific sexual behaviors. An individual driver of health risk can be focused more on health-related behavior, lack of information that's specifically targeted to prevent poor outcomes to the individual. Some individuals have low perception of risk as it relates to them. Medical mistrust, medical abuse, trauma, all these things continue to play a factor in increasing health risk. And of course, on a larger level, networks, who you know and where you function, sexual networks and social networks, cultural norms and stigma in your network, and the stress from heteronormity. And on a larger structural level, of course, social exclusion, gaps in research where transgender populations have been either misclassified or excluded from studies, lack of inclusion in public health campaigns, denial of healthcare based on gender identity, providers who are not knowledgeable about issues faced by gender diverse individuals, confidentiality concerns, they may not access healthcare for that reason, discrimination in laws and policies, and identity documents that don't match their identity and prevent them from getting proper care, exclusion from housing, education, and employment. All these things interact together to increase health risk. So how do we change this? So it could be as easy as 1, 2, 3 to change the narratives. One would be definitions and terminology. We have to know what we're talking about, and we're working on that today. 2, creating an affirming clinical environment. And 3, gender affirming therapies. So creating safer clinical spaces. So leadership and collaboration are very important. So being designated as a health equity site designation that it requires buy-in from leadership. Multidisciplinary referral services should contribute to building a safe institutional space. In our own personal offices, we can create welcoming environment with signs, forms that reflect patient's identity, patient materials, and the bathrooms. Of course, if you have gender neutral bathrooms, people will understand, clearly marked, people will understand perhaps that they're welcome as well. Training, we have to provide training for our staff, safe zone, retreats, pronoun workshops, special speakers, and invitations to activists, community members to come and talk to our staff and us, so we understand better the needs of the community. And of course, if you want to serve the community, you have to recruit and maintain LGBTQ identified staff. And it's great when it's our front desk staff, but it's even better when it's also our nursing staff and our provider staff. Needs assessments should be done for the community. What does the community need? You don't want to provide things that they actually aren't looking for. This is about what the community needs. So a needs assessment is always important. And of course, attend community events, be visible, and of course, if possible, engage in research that will be inclusive of the population. Changing the terminology. So gender dysphoria in DSM-5, it's a discomfort or distress that's caused by a discrepancy between a person's gender identity and that person's sex assigned at birth, as well as the associated gender role and secondary characteristics. The pathology is the dysphoria. The dysphoria is created by living in a society with a body that's incongruent with their identity, and they try to navigate their way in a world that discriminates against them. It's not the gender that's the pathology, it's the dysphoria that's created by an interaction with an unaccepting society. So gender incongruence. It's in the ICD-11 coming up. So it's renamed from gender identity disorder. And it's been moved to be recategorized under conditions related to sexual health out of the mental and behavioral disorders. So not everybody who is trans is dysphoric. Many people do have supportive environments and families and feel perfectly fine, and they're not dysphoric. However, they do have gender incongruence. It is a marked and persistent incongruence between the gender felt or experienced and the sex assigned at birth. So gender incongruence, it's a marked and persistent difference between experienced gender and assigned sex. And it's manifested by at least two of the following: a strong dislike or discomfort with one's primary or secondary sex characteristics due to their incongruity with the experienced gender, and a strong desire to be rid of some or all of one's primary and or secondary characteristics due to their mismatch with the experienced gender. A strong desire to have the primary or secondary sex characteristics of the experienced gender. So any, or at least really of any of these two would go along with the diagnosis of incongruence. The individual experienced a strong desire to be treated and to live and be accepted as the person of the experienced gender. The experienced gender incongruence must have been continuously present for at least several months. This isn't something you wake up one morning and, oh, hey, this is something that's developed over time. For many people, it's developed from their first perception of any kind of gender identity at a very young age. However, for some people, they've always felt something was off, but only through some time that they've actually understood exactly what it is. So a little bit about SOGI, sexual orientation and gender identity questions. So pronouns matter. So we want to respect the diversity of all identities, and we ask everyone for a chosen pronoun. We don't just ask people we don't know, we can't identify. We ask everyone. For example, our staff all wears pins with their pronouns. You can have pronoun signs in your office space talking about pronouns. Some of the questions we ask is what sex is assigned on your original birth certificate? How do you describe your gender identity? My pronouns are she, her, hers. What pronouns do you use? How would you like for me to address you? And how would you describe your sexual orientation? So we use Epic, and Epic, the version we already have, actually has this built in, some of it, and we are able to select gender identity, gender assigned at birth, gender current gender, and it also lets us choose then physical exams based on gender. So these are some of our intake forms that we use at the ID practice. We've actually gone beyond them right now because the university hospital that we practice in is also requiring specific questions being asked about people's sexual orientation that the state has asked us to collect. They've made me uncomfortable somewhat to have to ask these things of folks when they're walking in for their blood pressure checks, but I'm working on it. All the nurses on all the floors are also asking this at intake. Sometimes you have to be careful of what your needs-based assessment reveals to the people asking it. So we were all assessed as providers. What do you think is needed? And we all say we don't have this information to be able to make any kind of recommendations. Nobody knows what people's gender orientation, sexual identity is. Well, this is how they get this. It's now part of forms, and you have to ask people to fill it out. So be careful what you ask for, but still it's a good thing. So everybody's asked their sexual orientation, gender identity, and so forth. So words matter, gender identity, pronouns and names. We ask politely. People don't have to discuss this. This isn't something, anybody must tell us. We use the correct pronouns and identity and name consistently in interactions with individuals and in the medical record. If you make a mistake, politely apologize and move on. Do not assume gender identity or sexual orientation. It may be more difficult than usual to establish rapport with your patient because of mistrust, for example. Preface sensitive questions as to why it's necessary for you to ask. And if it's not relevant, don't ask. For example, in the case of cardiothoracic surgery and cardiovascular risk, it might not be important to find out whether your patient had facial fem or not. It might be because you might want to discuss their anesthesia reactions, but if it's a valve replacement and you already know they've had previous surgeries of other kinds without reactions, it might not be really needed to discuss their facial fem. So why is it essential to have pronouns and names in a hospital and clinic? It provides respect. It shows intent of because it's been shown that intentional lack of respect for identity can trigger feelings of invalidation, alienation, and dysphoria. In healthcare, this can lead to avoidance of care, rejection of care, defensiveness, poor coping mechanisms, and worse outcomes. Of course, all of us first do no harm. Respect and affirmation helps patients to focus on the healing process. Examples of pronouns, this is not exhaustive because they do change. People are more comfortable with some or others, but these are some you might see. For a transgender identity of woman or a cisgender woman, you might call them she, her, or hers. A transgender man or a cisgender man would be referred to as he, him, or his. A gender non-binary or genderqueer individual or gender non-conforming person might use they, them, or theirs, or a variation of z or zers, and there are really many others. So you would just have to ask. A little bit about the medical record. As I said, we use Epic. So some of the things you see in medical record is, remember, we have open notes now. You want to be careful what you write. I've had patients read their notes, like the psychiatrist notes, and then go back and ask me to please speak to them about changing some of the terminology they found in there because it made them feel not affirmed, for example. So it's affirming to use a note in your note, a transgender woman, a trans woman, a woman, she, her, hers. These are documentations we've actually seen on charts. Male dressed as a woman, male who wants to be known as Rebecca. In this patient's case, her name is Rebecca. Male who prefers to be referred to as Rebecca. Male who prefers to be addressed as a female with the pronoun she, he altogether. He, in parentheses, she's the preferred pronoun. I think someone, is trying to be helpful here, but still. And then, of course, my least favorite is the she, he, his, hers. Hate that. Very ugh. Others to avoid. I mean, these are older terminology, the male to female or the MTF. We try not to really use them anymore because it's patient-centered. So just call the person a woman or a trans woman or a trans man or a cis man, cis woman if they're not. And then, of course, transgendered, we don't use that terminology anymore. It's not like something that happened in the past. A person identifies as a transgender individual throughout their lifetime. So these are a little bit more about preferred pronouns and descriptions. And this is from the Division of AIDS Cross-Network Transgender Working Group from the ACTG clinical trials. So biological sex assigned at birth. Transgender individuals are biological beings, and biological sex makes people discount their identity. So the preferred terminology would be to use sex assigned at birth. Instead of sex at birth, again, sex assigned at birth. So it's assigned, not given. We don't say a transgender, whatever, you say a transgender person. The use of gender as a noun can be offensive to folks. Like I said, one of my least favorite is the transgender as opposed to transgender. It's stigmatizing nomenclature. It presumes that gender is something that happened in the past tense. Sex change. Now I've had older trans individuals actually use that, and if they're using it, they can use it. It's their body, and if they want to say that, that's fine. But I always will say that gender affirmation. So gender affirmation reflects the process somebody goes through to receive a personal and social recognition support for their identity and expression. Hermaphrodite is obviously not used anymore. It's an intersex person. It reflects better the modern scientific understanding of intersex conditions. So it's both misleading and stigmatizing. And essentially intersex individual has a disorder of sexual development and is not a hermaphrodite. Sexual preference, the preferred term is an orientation because it suggests that non-heterosexuality is a choice. And then women of childbearing age, this one's a little bit stickier. I think, it's more common for us to say that, but we want to say people of reproductive age because people of all genders have reproductive potential. Men and women, individuals might be better, or people of all genders, or you can be specific if you're patient is a cis man, then say cis man. If it's a cis woman, then say cis woman. If it's a trans, person, then say that. So some people might feel excluded. So how to take a sexual history. Now, I understand that the population I'm speaking to here, the folks in the audience are surgeons, and perhaps you might not be focusing on a sex positive approach, for example, during this thing, but it's still important to know, and we can talk about anatomy a little bit. So taking a sexual history, you want to involve the patient in the decision of when and how to communicate information about sexuality and gender identity. You want to tell them why you're asking. If it pertains for an importance for their health, then you want to know. If it's not, then there's no point to ask, and you want to make sure you communicate to the patient and the family of the confidentiality of your discussion. Use the patient's own language. A transgender, non-binary patient may use non-gendered language to describe anatomy. Use what they say. Some patients don't understand medicalized terms such as penetrative, insertive, or receptive. And some folks may embrace certain terms while others find them offensive. For example, queer. So young folks that I've seen in our practice embrace the word queer. They like the word queer. My spouse, who's been a teacher in a school district for many, many years, just cannot use that term. He says it's just horrible. He can't use it. It reminds him of childhood bullying on in elementary school, and people yelling things at people. So he said, if you want to use it, you use it. I can't use it. So you have to follow the lead of your patient. And of course, your patients will also be of different generations, and some might not like certain terminologies. A sex positive approach, basically follow the patient's lead, be open and clear and thoughtful and sensitive to their needs and comfort level, like you would of any cisgender, heterosexual, or as heterosexually identifying person, and of anybody else. So if you do need to take a sexual history, we do discuss it. I teach students and residents, of course, as well, and fellows. So we do discuss this frequently and how to take a sexual history. So are you currently sexually active? Have you ever been? What are the genders of the people you've had sex with? How many partners you've had in the last 6 months? How old were you when you first had sex? Now, perhaps, like I said, this is not something you need to ask as a surgeon, a cardiothoracic surgeon. But this is, if you ever had to ask, this is the recommended way of asking. Personal identity. What is your gender identity? What pronouns do you use? Do you have a name that's different from your legal name? How would you identify your sexual orientation? Past histories of STIs. Have you had an STI such as XYZ? Have you been tested for HIV or another STI? Would you like to be tested? It's always, as an infectious disease specialist, it is always a wonderful opportunity to test, to be able to be offer the patient testing for HIV, for example. Recommendation is at least once per lifetime over 18, or if there's a need. So we, for example, here in Newark at University Hospital have multiple entry points into our system. People are also tested and at our dental clinic. Why? Because it's always good to be tested. They still continue to provide whatever care they were providing, but they're also able to refer them for HIV care. So would you like to be tested? You don't want to be tested? That's fine. Have you current or former partners that have been diagnosed or treated for an STI? Pregnancy. What are your plans for conceiving or having a child? Are you concerned about getting pregnant or getting your partner pregnant? And these are all things you can ask folks whether or not whatever gender applies to them. Are you using contraception? Do you need information about this? I'll be happy to refer you to my colleague, XYZ. Practices and protection, if need be. There's ways to frame this. What types of sex do you have? Oral, vaginal, anal, insertive or top, or receptive or bottom, or both, verse. Do you use condoms, dental dams when having sex? How often? Do you have any other protection against STIs? If so, how often? And of course, for those of us who are doing primary care, do you have any concerns about sexual function or enjoyment? This might come up in an issue as well. If you have a patient post-surgery, you might need to be able to discuss with them recommendations about their sex life. So if needed, it's because they might be asking you. Additional important history for all patients. Higher risk activities, for example, sex work, anonymous sex, multiple partners, alcohol and substance uses used to enhance sexual experience. Their religious beliefs, for example, some people find spirituality as a source of resilience, especially those in supportive religious communities, while others have had a lot of hurt associated with previous religious institutions, and do not find that at all a source of resilience. You have to go by what your patient needs, and so you'll be able to best approach them. Trauma related to sexual history abuse. Has this ever happened to you? It has happened to people. Problems related to medications, body issues, or chronic illness, sexual dysfunction, and for us with patients who have higher sexual risk behaviors if they're on PrEP or things like that. So the approach for hormones and treatment goals. Basically, the goal is to alleviate dysphoria, engage in care. The point is not to just hormones, but it's to strengthen the patient-provider relationship, improve adherence to prevention and treatment services, and improve the mental health and overall well-being and reduce behavior risks. The treatment goals is to improve quality of life for transgender individuals by facilitating affirmation of a physical state that most closely represents their sense of who they are. Treatment is individualized. What helps one person may not be what another person needs. It may or may not include hormones or surgery. Many people have certain parts that are affirming to them in terms of care, and others do not. Like some people might not need anything. Some people who are, for example, some trans women may choose not to do anything and just live as a woman with some grooming or dressing as a woman. And that's fine for them, while others might want hormones, might want hair removal, breast augmentation, feminization, bottom surgery, tracheal shaves, voice therapy, and vocal cord surgery, and full feminization. It really is dependent, and everybody's experience is individualized. One cannot be less or more trans. It is how the person feels, and should be no judgment about how much a person does as it regards to their identity. They're no less trans if they're just dressed as a woman than if they've had bottom surgery, for example. So criteria for starting gender affirming hormones. Just to go over very quickly, it is a persistent, well-documented gender dysphoria. And remember, the dysphoria was discomfort with their gender identity, not just incongruence. The capacity to make a fully formed decision and consent to treatment, the age of majority in a given country. I'm sorry. If it's a significant medical or a mental health concern are present, it must be reasonably well controlled. Living in a gender role that's congruent with their identity, quote unquote, social transition, is no longer required for hormones as a prerequisite, because for some people living in unsafe environments, that might not be possible. Informed consent. So like all medical treatments, benefits and risks must be discussed. We no longer need to have people sign on things, but they do need to give informed consent. And if it's given, we want to document. So all hormone therapy may lead to irreversible physical changes, infertility, breast development, bone density decline, and genital changes. A little bit about the physical effects of feminizing hormones. And this is available from the Endocrine Society practice guidelines, as well as also from the standards of care and the Callan-Lord hormone guides. So, but basically, as you could tell, side effects might begin early, while actual muscle mass change, fat redistribution, and breast growth might take up to 6 months to even start developing at all, and continues for years. Voice change, though, something important to know, voice change does not happen in estrogen. It happens in testosterone, but not on estrogen. So potential risk of feminizing hormones. While we do know that increased venous thromboembolic disease, hypertriglyceridemia, it can certainly cause infertility, because you're not going to, your patient might not be able to produce sperm. Liver inflammation, it does cause weight gain, maybe gallstones, maybe acne, maybe not. And of course, spironolactone can cause hyperkalemia. There might be increased risk of cardiovascular disease if they have additional risk factors like smoking and family history of cardiovascular disease. Hypertension could be an issue for some people. It's rare that they might get a pituitary tumor, but we do monitor if there's any headaches. We no longer do routine prolactin levels, but if they're symptomatic, we will. Depression and anxiety, certainly. And, hormones can have an effect on your mood. And, diabetes, if you gain weight and you have family history, that's certainly possible. Now, breast cancer studies are still out, but however, if you have a family history of breast cancer or have a BRCA gene, and now you're on steroids, on hormones, estradiol certainly might increase your risk of breast cancer because you have breast tissue. So these are some of the estrogens, progesterone, and androgen blockers used in the United States. Outside the United States, they have more available blockers, but in our practices, we typically use estradiol, either orally or intramuscular. I know some folks out in California were advocating sub-Q, but I haven't seen it used here much. So estradiol supinate, estradiol valerate, you can use an estradiol patch. If your patient smokes, that might be safest. If your patient is over the age of 45 and you still want to do this, that'd be a good idea. Perhaps safest. Methylprogesterone is added sometimes. Hydroxyprogesterone. We also used micronized progesterone. And for most androgen blockers, you're talking spironolactone or finasteride. Physical effects of masculinizing hormones would be also, there's some things that begin early, but as you could tell, for some, such as voice change, increased muscle mass, and facial body hair, that might take up 6 months to a year, but generally testosterone is a very masculinizing hormone. So most voice changes, there's, within a year, your patient will sound definitely masculinized. Of course, testosterone carries its own risk. You can have polycythemia, increased visceral fat gain. It can cause infertility. We encourage our patients, if they're considering child rearing at some point of quote unquote their own biological children, would be to do preservation of both sperm for trans women and eggs for trans men prior to start of hormones, if possible. It can cause acne, alopecia, of course, and sleep apnea on folks that might gain weight. There's some liver inflammation risk, but that could be with both estrogen and testosterone, of course. And of course, also depression, anxiety, psychiatric sort of effects. Hormones can make a difference. It's unclear in terms of osteoporosis risk, but it might be higher if somebody's had a oophorectomy, especially if they stop testosterone. So they will not have any hormones for ovarian health. For bone health. Though breast and cervical cancer are lower in trans men than in cisgender women, it's not impossible, especially if there's breast tissue still retained, but the studies on that are sort of ongoing. And there is no really conclusive evidence that ovarian cancer is increased with testosterone. So these are the testosterone forms that are used: testosterone supinate or ethynate, either sub-Q or intramuscularly. There's an auto injector, kind of like an EpiPen, that could also be used, of testosterone anaphylate for those who don't like needles. There's a testosterone gel, testosterone patch. The testosterone udoconate capsules that became available in the US like about 1.5 years ago, was more common in Europe. There is also a injectable product, but I can't say that's commonly used, and probably not around here, and not by a patient. It would be used by a physician somewhere else. So additional counseling. Hormones may not be able to meet all personal goals. You really have to ask your patient, what is it they're hoping to achieve? Hormones alone will not have all their facial hair stop growing, for example. It will not regrow lost hair from alopecia. It will stop, for example, further hair loss, but it will not. If you were bald when you started, you're not regrowing hair, so it's going to need to be put in through implants or what have you. So results vary from person to person. The full effect can take 2 to 5 years of continuous therapy, and we always consider reproductive concerns. If somebody wants to have children, we want to discuss this before start of hormones, and if they decide while they're on hormones, we'll have to discuss how to safely do that and how to stop, and then refer them to our reproductive endo colleagues. And of course, contraception if pregnancy is a possibility anatomically. So trans men when non-binary individuals who were assigned female at birth, who have sex with people who are assigned male at birth. The label here might not matter. Basically, if an anatomically sex practice can cause pregnancy, then they should be on birth control because testosterone is not a contraceptive and it is teratogenic. Trans women or non-binary folks who are assigned male at birth, who have sex with individuals who are assigned female at birth, can also, even if they're on estrogen, perhaps engender a pregnancy. You never know. There might be drops in hormones. So your own personal identity does not necessarily mean you cannot engender a pregnancy or have a pregnancy. So you have to discuss contraception if it's biologically possible for them to get pregnant. So initial and monitoring blood work. So there's not that much blood work, honestly. We do initially regular sort of blood work, CBC, a comp, lipids. We personally also do STI sort of testing and hepatitis A and B and gonorrhea, chlamydia, and also test for hep C, which is recommended at least once in everybody over age 18. And we also do TB screening because our setting is urban, and we also have a lot of folks coming in from outside the US who are immigrants and now are full-time residents and things like that. So in 3 months, we'll be checking at least the basic med if they're on spironolactone, a CBC if they're on testosterone, because you're concerned that about polycythemia, and we do check hormone levels, which is estradiol for those that are trans feminine, and testosterone for those that are trans masculine. And in 6 months, we also do lipid testing as well as the hormone levels. And at 12 months, and then afterwards, yearly hormone levels, CMP, CBC, and other tests based on personal risk. So such as a hemoglobin A1C, prolactin level, if there's a concern about a pituitary tumor, and HIV and STI testing. And if somebody's had a gonadectomy, then you want to check LH and FSH and free testosterone. So a little bit about gender affirming surgery. So especially bottom surgery. One opinion, one option is in supportive initiation of treatment from providers needed, at the very least. 6 months of continuous hormone therapy is appropriate to the patient's gender goals, unless the patient had a medical contraindication or it can't or unwilling to take hormones. So if somebody had breast cancer, for example, you would not be then, giving them estrogen necessarily. So they might not be on hormones at that point, and they still might want to have bottom surgery. In the past, this used to be, they needed multiple levels, multiple letters, like 2 from mental health providers for bottom surgery, 1 at a doctorate level, and they had to be on hormones for over a year. So the latest guidelines from WPATH suggest they're more liberal and suggest only 1 letter is needed and 6 months of treatment. However, most insurance companies in this area are still requiring 2 letters, 1 from the medical provider and 1 from the psychiatrist, preferably, or a psychologist, somebody with a PhD or doctorate level, at least in this area. If they have for bottom surgery, if they have somebody who is like an MSW, a licensed clinical social worker, they will still need to bring 1 from a doctorate in this level person in this area. It is very gatekeepy, so it took a while to get where we are with the insurances covering what they cover around here, including Medicaid. So it's going to take a while longer to probably get them to go along with the WPATH recommendations in version 8. So living in a gender role that's congruent with gender identity is no longer mandated because it might not be safe for that person to do so. They might not be unable to do so. However, additional assessment is suggested when social transition is unwanted or there's no clear plan for social transition. So if somebody just shows up and wants to have bottom surgery, but is still planning on living in the gender they were assigned, it's really, they're going to need a further exploration really of why this is what they need if you're going to proceed this way. So Reduction in mental health treatment utilization among transgender individuals after having gender affirming surgery, a total population study. So they went, and this was from Sweden, a total population registry. Between 2005 and 2015, they had over 2,000 individuals. And then they looked at them to see what compared with the general population. Those who had gender incongruence were about 6 times more likely to have a mood disorder than others, and received medication, antidepressants, what have you, and it maybe is 6 times higher. They've been hospitalized after suicidal ideation. However, giving them surgery improved their mental health needs and decreased their utilization of surgery. So a little bit about detransitioning and regret. I'm not going to say that I have not met people who had experienced quote unquote detransitioning, and people who've experienced regret. The more people we see in our practices, the higher the likelihood that an individual person would be experiencing something like this. However, detransitioning and regret are not synonymous. So detransitioning, which is about between 1 and 10%, is more frequently temporary, and it's usually associated with societal, familial pressures, safety, or medical concerns, including fertility preservation. And transition isn't always linear, right? So you start hormones, you live like 5 years in your gender, and then you decide to stop for some reason because you can't get a job, as one of my patients said. And another patient had severe pulmonary issues and just was in and out of the hospital the whole time. And it was just easier they felt for them to be treated as a male than as a female, because they didn't have to explain anything. So they just stopped everything and said, I'm going to wait till I'm done with my pulmonary situation. Regret is rare. So when we're talking about regret, you're talking about less than 1%. This is best described in surgical literature, and this is the most common reason cited for this: is societal stigma and community and familial rejection. Of course, there's also a tiny percentage of misdiagnosis in gender identity, like many other things. And of course, evolution of gender identity can be also better understood. For example, I personally do have a patient who had both top and bottom and facial femme and all kinds of surgeries by age of 22. They are now close to 30, and they have had some of the facial femme and their top surgery, things like that, removed. They do not necessarily regret or hold anybody responsible for what's happened, that this has happened, but their understanding of their gender identity has also evolved over time. And now, they don't feel that they're really trans feminine. They feel like they're more neuter and neither. And if they had to go back, they might not have had some of the surgeries they had, but they're in a minority. And I've only met, 5 or 6 people who had detransitioning or any kind of regret. And of the detransitioning, 3 had to do with religious reasons. And actually, they when they got over their initial fascination with reconnection to faith, they actually resumed hormones again. So, the more people you see and the more people you treat, and the higher the population we treat with gender incongruence and gender dysphoria, there will be folks who do change their mind, but it's a very tiny proportion and generally quite rare. So mental health care, much more common is, of course, mental health issues in our patients, such as anxiety, PTSD, OCD, ADHD, autism spectrum disorders, among others. Patients may require ongoing management of these conditions, and many insurance companies will require letters from mental health professionals prior to authorizing surgeries. They have to confirm the diagnosis of gender dysphoria or incongruence, attest that the patient would benefit from surgery to alleviate gender dysphoria, and provide any perioperative guidance for the management of comorbidities. So a little bit about surgery, since I am talking to surgeons. So trans women, chest feminization, orchiectomy, penile inversion vaginoplasty, intestinal vaginoplasty, labiaplasty, tracheal shave, vocal cord surgeries, facial femme, and liposuction, augmentation of buttocks and abdominoplasty are some common procedures. Trans men might have chest masculinization, hysterectomy and oophorectomy, a vaginectomy, medioplasty, urethral lengthening, which is generally has side effects. The medioplasty and the urethral lengthening do have a lot of post-op issues. Phalloplasty, you can use a radial forearm or a thigh flap, and scrotoplasty. So compliments of my surgical colleagues. These are, this is a picture of a penile skin dissection to create a neoclitoris and some more skin pouching. And this is, oh, I'm sorry, apologies. So yes, sorry about that. And this is the creation of neophallus with the graft from the thigh. A little bit about preventative care in our population. Smoking cessation is a big thing. We don't like people smoking on estrogen or testosterone for that matter, and treatment of coexisting substance use disorder is also encouraged. We vaccinate folks based on the ACIP guidelines. There's no necessarily change in vaccinations. DEXA for osteoporosis screening might need to begin at 50 versus 65 because of the many years of suppression of hormones for bone health, especially if somebody had an oophorectomy or other forms of like another gynoplasty. Breast cancer screening. So trans men can get breast cancer. It's going to depend on hormone use and how much breast tissue is left. If you don't remove all breast tissue, you're going to need to have mammograms. Trans women, we start screening with mammograms after age 50 and 5 years on hormones. Silicone may affect interpretations. You might need an MRI. We follow guidelines for other age-appropriate cancer screenings based on the organs present. If there's a colonoscopy, if they need screening for colon cancer, they need a colonoscopy. If they still have a prostate, which does remain, whether or not somebody had when they have a neovagina, they still retain the prostate, so they will need a prostate exam, and that is best done through the vagina in those that have one surgically. So we still do cervical cancer screening. We do anal pap screening as well, based on individual risk. And we do surveillance for abnormal vaginal bleeding in those who still have a uterus. So we do HIV prevention education as needed and risk appropriate STI screening and pregnancy prevention counseling if indicated. So healthcare needs for transgender non-binary folks: respect and safety and a sense of belonging. Remember the pronouns, the forms, the patient material, and of course the bathrooms, gender affirmation, medical treatments that help affirm that, tailored preventative care, mental health care, and community and familial support, especially in youth, very high risk of suicide and depression in families that reject those children. So the more familial support for a young person, the better. High quality and accountability of primary and acute care, vaccinations, cancer screening, person-centered comprehensive care, and of course, support of any kind of opportunities to thrive. We want support from leadership and support of other social determinants of health that transgender non-binary folks experience. And that's pretty much it, other than this little thing over here, where this little website called bridgenj.info that provides some resources that we have developed for community as well as trainees and all who are interested in gender diverse care. So I am going to stop sharing my slides and open up if anybody has any comments in the chat to answer.
Thank you so much, Dr. Finkel. I just really want to stress, to thank you for being here today and to just recognize that a lot of what you taught me tonight, I did not know at all. And I do feel like it's important for us to have insight as cardiothoracic surgeons into these issues, because they are our patients. And I appreciate that you took the time to show us some of the sexual history and things that you said you may never be asking this, but in the event you do, this is how to do it. But I do want to really emphasize how important it is to provide culturally competent care, and this is a big part of it. And these are our patients, and appreciating who they are and understanding who they are will improve how we take care of them and help reduce these healthcare disparities. I just can't emphasize it enough. When I was talking with some of my colleagues and residents about our having this webinar, I was told the story even this week at another center where a patient who preferred to be referred to as their surgeon refused to do that. And I just can't, it's disappointing, but I think ongoing work from people like you and the rest of our community to help emphasize how important it is to understand who our patients are and what their needs are will help improve that situation.
I think a lot of times when you don't expect to encounter in the course of your work somebody who's gender diverse, for example, you might kind of be thrown and not know the right thing to say or how to say it or how to ask. That's something a lot of surgical residents tell me, that they really weren't thinking about it. And there's a kid with a broken leg and they're like, okay, it looks like the chart says male, but this person looks like a girl. So should I just ignore it, not ignore it? What should I be saying? What should I be doing? They really are interested in, their leg, they want to do, ortho and, but they still want to treat their patient with respect. So, unless you practice how you do it and what you say, you might not be able to know in the course of an acute encounter the right terminology or how you should address the person. So that's why we practice. Extra points for cats, always.
Sorry, she always knows when I'm on a Zoom call.
Yes, as did my child, who I just kicked out of here a little bit ago, who wanted to get on the Zoom, but I said.
That was great, Dr. Finkel, and thank you so much for going over this important topic. One thing that I think would relate to as surgeons is the patient who's on hormones, who is then in the hospital, NPO. What do we do? I mean, do we consult? Would we consult you? Would we ask the patient preoperatively who their physician is, so that way we can discuss it with them?
So you probably would do all of the above depending on your practice setting. So where I practice, you would consult us, myself or two of my other colleagues who provide gender affirming care, and we'll be happy. We're just downstairs, in the clinic, and we do certainly do hospital consults, and you'll just call us and we'll come and help you, which we'd encourage. But let's say you had a person who was referred to you for cardiothoracic surgery, and their provider doesn't go to your institution, and they live 3 hours away. So you're always welcome to ask them pre-op as part of the recommendations, and that is actually something we put in our letters when we do gender affirming surgery referrals. But I don't see why it wouldn't be something you could ask their doctor when they're clearing them medically, or quote unquote evaluating the risk for surgery. We don't clear folks anymore, I hear. So so evaluating the risk for surgery, what they'd be doing most of the time. If they can wait a day or two as far as estrogen or spironolactone, for example, is concerned. If they're on PO for a day or two, you're not probably giving them much of anything. And also in the hospital setting, you can convert oral estradiol to a patch, for example. So if you're concerned about not being able to administer something orally, so you can give them a transdermal patch of estrogen as well. And as far as testosterone, since it's only dosed most of the time, though there is that new oral medication, but it's usually dosed intramuscularly or subcutaneously or through a gel or there's even a nasal spray, you might have less issues with that.
Thank you so much, Dr. Finkel. I want to be respectful of your time. Are you okay with us disseminating just the information how people can reach you? I think this should be part of education programs for our faculty and our residents. I think that could be a very useful way for people to help apply this. And I think just even understanding that it's okay to ask. And it's better to ask for guidance than it is to just ignore or worse yet, unintentionally offend or alienate patients.
Of course, and there, you feel free to use our slides to distribute them. And there's actually mentorship programs for surgical trainees and surgeons who actually want to engage in this sort of educational curriculum development. One of our residents is, what did he call it? Give me a second. I thought it was kind of cool. He went out and found mentorship through surgical societies in terms of, okay. Yes. So apparently there is an association of Outsurgeon and Allies. It's called AOSA. It participates in surgical education research fellowships funding. So he's a fellowship through the Association of Surgical Education. And his fellowship it's called SURF, Surgical Education Research Fellowship, where he's going to be mentored to develop curriculum for all surgeons in this.
That is outstanding. Thank you again. And I think just to help wrap up, again, as we celebrate Pride Month, we really appreciate your time and we appreciate the audience who attended the webinar tonight. And we look forward to continuing to learn and providing better care for our patients.
Thank you so much. And thank you for the opportunity to speak. Take care.
Good night all.
Good night.